Hi, everybody. This is Laura Doherty, the National Clinical Manager at Functional Formularies. Thank you so much for taking time out of your busy schedules to join our webinar this afternoon, Navigating Ethical Dilemmas in Artificially Administered Nutrition and Hydration, a comprehensive review. This has been approved for one continuing education credit by CDR. It does count as an ethics credit if that is something that you are needing in your portfolio. Just a few housekeeping rules before our amazing speaker gets started. We are going to have a Q&A at the end. You can type your question into the questions box through GoToWebinar, and we will get to as many questions as we can. The handouts, a copy of the handouts, the slides, the references, and the certificate is available in the handout section. We will also be emailing everybody that's in attendance today a copy of those as well by the end of the day tomorrow. So 2 places to get your certificate and your slides, either in the handout section or again in the email that we send out. We will also be having a survey after the webinar in that email. Please fill out that survey. It helps us get better at our webinars that we offer, allows you to give your feedback, which is always very much appreciated. With that being said, I want to introduce our speaker this afternoon. Stephanie Dobak is a clinical dietitian at the Jefferson Weinberg ALS Center in Philadelphia, Pennsylvania. In this role, she provides nutrition care to people with ALS and manages all enteral nutrition regimens at the center. Stephanie's ALS research has focused on standardizing nutrition care, discerning the ideal time for gastrostomy tube placement, implementing interventions to increase quality of life, and optimizing advanced care planning discussions. She's the co-founder of www.alsnutrition.org, the only website dedicated exclusively to dietitians treating people with ALS. Stephanie is also the co-chair for the nutrition subcommittee of the Northeast ALS Consortium. So with that being said, I'm going to hand it over to Stephanie to share all of her knowledge and passion. Thanks, Stephanie, for joining us today.
Thanks, Laura, and thanks to everyone for joining us today. I know ethics can be controversial and intimidating. It could be a little bit dry at some points, but my goal is to make you feel more comfortable in having these difficult conversations with patients and families, and also the other members of the interdisciplinary team. I have a couple of disclosures that I do receive grant support from the Dietitians and Nutrition Support DPG, as well as the ALS Association, and I receive speaker honorarium from Functional Formularies. These are our objectives today. The first one is to understand the fundamental ethical principles surrounding artificially administered nutrition and hydration. And that's such a mouthful, so I'm going to be referring to it as AA and H during the presentation. And a little bit of side note, it used to be called just artificial nutrition and hydration, and you might still see that in the literature. But we know many people use blenderized foods for enteral nutrition. A lot of the hydration is water. So they added the word administered to clarify that the route is artificial and not necessarily the nutrition and hydration. Our second objective is to develop effective communication strategies for discussing ANH with patients and their families. And then lastly, we'd like for you to gain access to practical resources and case scenarios to enhance understanding and implementation of ethical frameworks and decision-making processes in clinical practice. I know a lot of you are familiar with the 4 principles of bioethics from your undergraduate studies, but I'm going to briefly review them as they set a framework for our discussion today. Starting at the top with autonomy. Autonomy refers to the right of competent adults to make decisions regarding their health care. And the intent of this ethical principle is to ensure patients are fully informed of their healthcare options, that they're involved in the decision-making process, and that their healthcare preferences are respected. It is not meant to be a free-for-all or to imply that individuals can have whatever medical therapies they request, because we do know that therapies may be inappropriate and even harmful given a patient's disease state or disease trajectory. In terms of autonomy for children, the same rules apply regardless of their prognosis. We do want to respect the child, and give them a developmentally appropriate description of their condition, and then also with expected burdens or benefits, and then solicit their preferences. The next one is beneficence. So beneficence involves working in the patient's best interest in light of their clinical status. Again, we always want to use evidence-based medicine. Also, as much as possibly medically, we want to incorporate the patient's personal and quality of life goals when determining what's best for them. Non-maleficence is doing no harm to individuals, and this could mean not providing AANH to a patient when the burden or risks outweigh any benefits. You, as a clinician, are not ethically obligated to provide AANH if, in your clinical judgment, there's no adequate evidence for the need of the therapy, or if you deem that the risk or burden outweighs any benefit. And then lastly, we have justice, and that revolves around the fact that, unfortunately, we live in a world with limited resources, and we want to make sure that we distribute those resources with fairness and equity in order to benefit the most people. Essentially, clinical ethics is grounded in patient-centered care, and the goal is to achieve optimal, equitable healthcare, providing the most benefit with the least harm while keeping the individual patient in the forefront of our minds. Okay, so you've come across a difficult case in which the outcome is contingent on the decision to move forward with AANH or not. Let's say the patient had a major stroke. They have severe dysphagia. The family's undecided that the patient should start on enteral nutrition or just transition to comfort measures. And there are some key elements to have in place prior to going into these care plan meetings. Obviously, we want to involve the patient or the surrogate decision maker. The surrogate decision maker or the legal power of attorney is the person previously designated by the patient to make important healthcare decisions on their behalf if the patient was ever incapacitated and couldn't make decisions. Again, we want to align those 4 principles of bioethics while also considering the patient's preferences, their personal goals, any sort of cultural or religious beliefs. And we definitely want to ask before the meeting who on the family side is a surrogate decision maker or power of attorney, as well as who are other key members in their life that they might want to include in this decision, like religious leaders. The surrogate decision maker should make decisions based off the patient's best interest and values, not their own, which I know can be a little bit difficult because unfortunately, many individuals do not discuss their values or goals of healthcare with their family or surrogate. It's not like it's Thanksgiving dinner. It's just like, hey, what would you ever want if you had a major stroke? Hey, can you pass the peas, grandma? That doesn't typically go down, and they might not have an advanced directive saying what they would want. So know that it can be really difficult for surrogate decision makers to make these decisions for their loved ones. Next, we have an advanced directive. An advanced directive is a legal document that outlines a person's wishes for their medical care if they were ever unable to communicate that information themselves. So prior to providing an AANH, I encourage people to look to see if there's an advanced directive on file, and if so, what does it say? But we do know that advanced directives are limiting. They state wishes for, many of the advanced directives state wishes for if a person is ever in a terminal state. And, for our patient, maybe they had a large stroke, but it's not technically terminal. They might have not updated their document in decades, despite changing their opinions or values on what they would want. And they might not have communicated that to anybody. So we know that while an advanced directive can be a guide, it can also have its limitations. Next is the IDT, or the interdisciplinary team. It's important to decide upfront who from the interdisciplinary team should be present at these meetings with a patient or in their family or surrogate decision makers. So invite palliative care, invite pastoral care if that's in the family's wishes. In the case of our patient with a stroke coming down to enteral nutrition, invite the speech pathologist, invite the dietitian to see, what's the probability of the patient resuming swallowing function versus what would life look like if they were to get enteral nutrition and then possibly a PEG. And then lastly, we have bioethics committees, and these can really help with more controversial cases where a conclusion can't be made despite the interdisciplinary team's best efforts. The bioethics committees can also serve in an advisory role for the unrepresented patient. So the person that doesn't have an advance directive, they don't have a power of attorney or surrogate decision maker, they don't have an next of kin, the bioethics committee can serve as a proxy for them. Most medical societies have position papers on AA and H, and all endorse the view that AA and H, whether delivered parenterally or enterally, is a medical intervention. And like other medical interventions, such as mechanical ventilation or dialysis, AA and H should be evaluated by weighing its benefits and burdens in light of the patient's clinical circumstances and goals of care. But having it be viewed as a medical intervention can be discordant with how patients or families view AA and H, because many individuals, many religions believe that nutrition and hydration are basic or what might be considered ordinary needs, that they're not this medical intervention and that they need to be provided no matter the route of administration. So it can really be difficult for some patients or families to receive the medical team's description of AA and H as a medical intervention and not something that is ordinary and basic and needs to be provided no matter what. All right, so you're sitting down with the family, they're deciding if their loved one with a stroke should start enteral nutrition. This may be a good time to discuss withholding versus withdrawing of therapies. From the medical standpoint, withholding and withdrawing are considered morally, ethically, legally equivalent. There's no difference between the two. The term for both is considered foregoing a therapy. And this image depicts the similarity between the two. So each solid vertical line on the withdrawing represents a day on AA and H prior to a period of no nutrition support, represented by the dotted lines. So whether the patient is already receiving AA and H or not, the decision to not provide AA and H at one point or another will have the same ultimate result, that the patient goes without nutrition support at some point. So if it would have been morally permissible to have withheld the therapy and let the patient go without it, then it's also morally permissible to withdraw that therapy. However, from my experience, I will say it's more emotionally taxing to withdraw ANH than to withhold it. Families or surrogates are more likely to feel like they're pulling the plug and causing death by starvation if they withdraw ANH versus if they had never started it to begin with and the patient passed away. It's really important to stress that the disease leads to death. And really, at the end of life, the body produces endorphins and other protective measures to decrease appetite, so one isn't suffering from the sensation of starving. In addition to personal burden in making these decisions, again, there might be religious or cultural beliefs about withholding versus withdrawing therapies. So while medical professionals view them as equivalent across the board, they might be quite different from the viewpoint of the patient and family. And lastly, when the efficacy of AANH or the overall prognosis is uncertain, it's advisable to consider administering AANH on a limited time trial basis. So prior to initiating the trial, it's really important to have a clear game plan with the patient and family. We want to ensure that they know and agree upon that this is a trial period. And you want to work with them to come up with mutually agreed upon criteria and a time frame for reevaluation. For example, let's say we had a young person admitted with significant injuries after a car crash, so really traumatic for the family. The prognosis doesn't look good, but the family believes it's too early to move to comfort measures. They're not there yet. They want to give it more time. That's completely understandable. So if it's reasonable from a medical standpoint, you can discuss it as an interdisciplinary team. And then later with the family, the appropriateness of starting nutrition support. Always agree upon a time frame to provide the nutrition support. So say you're going to provide it for 3 days or 7 days, whatever is most appropriate, given that case, and discuss that when you get to the end of the trial period, you're going to talk with them, reevaluate continuing versus stopping the AANH. But also verbalize that if AANH ever causes harm prior to the end of their trial period, say they're vomiting their tube feeds, they're getting significant fluid overload from the TPN, you'll stop the AANH before the end of the trial. Clinicians should always assure the patient or family that if therapies are withheld or withdrawn, that the individual continue to receive care. They're not going to be abandoned, because I think that's a lot of fear for families. Getting to the bulk of our discussion today, I'm going to focus mostly on the 2021 ASPEN position paper on ethical aspects of AANH, which is a fantastic paper. The paper addresses concerns of potential ethical issues in specific populations. So they review people in a coma or with decreased consciousness, those with advanced dementia or cancer or eating disorders, which I think is a fantastic and really interesting section on the paper. End-stage disease or terminal disease. During this presentation, we're going to focus on the recommendations for these three populations: the people with advanced dementia, cancer, or end-stage disease and terminal disease. And we're going to start with advanced dementia. So studies have noted that nearly 90% of individuals with advanced dementia suffer from eating problems like dysphagia. So the topic of AANH often comes up in this population. Unfortunately, the studies have showed that AANH neither stops dementia, disease progression, nor prevents death. Therefore, the decision to forego enteral nutrition in end-stage dementia is supported by evidence-based medicine. Advanced dementia is considered a terminal illness as it's a progressive disease without cure. And we as healthcare team members should clearly communicate this perspective to the patient's family. Going back to advanced directives, many advanced directives state what a person would want if they're ever in a terminal disease state. So wishes expressed on advanced directive do apply in the cases of advanced dementia. Many studies have investigated the impact of PEG tubes in people with advanced dementia. And there's a great Cochrane systematic review and meta-analysis by Lee, which I've cited on this slide. But starting at the top, when compared to hand feeding, PEGs do not increase survival time after advanced dementia diagnosis, but instead they might be associated with increased mortality, which is death during the study period. Regarding aspiration pneumonia, overall, there appears to be increased risk of aspiration pneumonia with PEG. And this was really interesting to me because I figured with a PEG tube bypassing the oral region, it would decrease aspiration risk. But enteral nutrition can increase the risk for reflux. In addition, unfortunately, oral hygiene is often neglected in people with dementia, especially those who get PEG tubes. So these people are aspirating on their own secretions or saliva, which are now dirtier from the lack of oral hygiene, and that can lead to pneumonia. Next up, we have pressure ulcers. So there's an increased risk for pressure ulcers with people with advanced dementia who get PEG tubes. Again, you might think that they're receiving appropriate nutrition to prevent the wounds. However, because they have a foreign object, a tube hanging out of them, because they're impaired cognitively, they might pick or pull at the tube. Then they're going to have to be restrained, either physically to a chair or chemically with something like Haldol or Ativan. The more nutrition you put into the body, the more that comes out. A lot of times they're incontinent, so they're now sitting restrained in urine and possibly feces, and that leads to skin breakdown, which increases the risk for pressure ulcers. And lastly, PEG tubes don't positively impact nutrition. I will say that nutrition status was defined in these studies as changes to albumin, which we know isn't the greatest indicator of nutrition. Some looked at hemoglobin or anemia. However, even when considering weight changes, study results are mixed, with one study saying maybe a PEG increases weight, with another study showing it doesn't impact weight. Ultimately, it can be a really tough decision to decide whether or not to pursue PEG for those loved ones that are making this decision for their loved ones with the dementia. There's a study by Zane et al., which interviewed caregivers who reported internal conflicts about not providing nutrition support to their loved one with dementia. And the concern was that not feeding them would lead to death by starvation. In addition to internal conflicts, there's external conflicts, right? You usually have other people pouring into the decision-making process. So you might have other family members who have differing opinions on whether or not to pursue a PEG tube. So really discussing the evidence-based medicine and alternatives such as comfort or oral feeding instead of ANH may help reduce the guilt of the family making that decision. And it's also really important to mention that enteral nutrition can decrease quality of life by taking away oral intake. We know that you can eat with a feeding tube, but the reality is that a bolus tube feed is a lot quicker. So sometimes, especially in nursing homes, they're going to be kept in their room and given a bolus tube feed instead of being brought out to the common area and allowed to eat and be able to taste foods and socialize. So again, you know, if we even have an advanced directive, we can rely on that too to help the surrogate decision maker make those decisions for them. Okay, we're going to have polls coming up here, but here is our case scenario, is that we have a 68-year-old man who had early onset dementia and has had it for 5 years. He has had a gradual but significant weight loss since his diagnosis. His BMI is down to 17.3 due to dysphagia, which continues to worsen. He's had 2 bouts of pneumonia over the past 6 months, despite being on this medicine moist diet with mildly thick liquids. In addition, he'll often forget to eat and forget how to feed himself, but he will eat with assistance and encouragement. The patient had stated in his advance directive that he would not want AANH if ever in an incapacitated or terminally ill state. However, his daughter, who is the power of attorney, believes that the PEG is in the best interest of her father, given his dysphagia and weight loss. All right, so I'm going to pull up a poll for you guys to participate. So do you move forward with PEG? Okay, so hopefully you have that poll on your screen, but yes, the daughter's a power of attorney. She wants to pursue the PEG tube. No, looking at the evidence-based medicine, there's evidence that PEG would not benefit the patient and may in fact cause harm. So looking out for that beneficence and non-maleficence. Well, then maybe it really depends on the factors. Is he ambulatory? Is he going to need restraints? So I'm going to give you a little while longer to answer this. Okay. And it looks like 50% say no, you know, looking out for that beneficence, non-maleficence. 37% say it depends on the factors, and then 15% say yes, the daughter is the power of attorney, and she's able to make decisions. What is that poll? Okay, so I am a dietitian, just a stereotype dietitians. We tend to be very type A. We like our black and white, everything in a box, things that are very easily discernible, yes or no. It's not that case in these sort of discussions, which I think is fun. It adds to the interest of having these conversations. So saying that there's not necessarily a right or wrong answer, it really depends on the case. Generally with this sort of case, I would say no. We do want to respect the daughter's opinions and concerns and validate that her concerns are true. But we also want to gently communicate the PEG's lack of benefit and potential harm for her father, given the evidence-based medicine. We can always point back to the advance directive, show that he wouldn't have wanted a PEG tube. And we can also discuss that though he's losing weight, he doesn't appear to be in any distress. So he's not suffering from the sensation of starvation. And he does eat, and when it's comfortable for him and when he's able to eat. Right, now we're going to switch over to ANH with cancer. And when we consider ANH for people with cancer, this definitely is a group of people who can benefit from enteral or parenteral nutrition. But first, we want to work with a physician to ask, what's the prognosis? Is it good? Is their overall survival months or more? Or is it a poor prognosis or rapidly progressive disease in which they only have weeks or less to live? Similarly, what's their tumor activity like? Are they responding to treatment well? Next, we want to consider their performance status, which can be measured by the ECOG. The ECOG performance status scale quantifies a patient's level of function in terms of their ability to care for themselves. So think about those activities of daily living. Can they feed themselves? Can they conduct personal hygiene? What's their physical ability? Are they able to walk, move around? And the scale ranges from 0 to 5, with actually 0 being the best, the highest function. So good performance status, an ECOG less than 3, is associated with better outcomes from palliative nutrition support, such as these people might have improved quality of life, longer survival with the nutrition support. Before ever initiating AA and H, again, we want to discuss it as an interdisciplinary team. What are the risks? What are the benefits? Then we want to have that discussion with the patient and family and really talk to them about their personal care goals, because those can differ dramatically depending on the person. Maybe they want to live as long as possible. Maybe it's the opposite. Maybe they're unhappy with their quality of life. They don't want to prolong suffering. A lot of times there might be a life event that they want to get to, like a wedding or a birth of a grandchild. And then we want to talk with them about their goals, but also relay the risk and benefits in light of their prognosis. If there are plans for home nutrition support, we also want to consider their ability to manage the nutrition support at home and their insurance coverage. So how much of a financial burden is it going to put on that patient or their family? Okay, so let's say they're moving forward with AA and H. Over time, the cancer is either going to decrease or progress. And we know goals of care might change throughout the way. So we always want to have these ongoing discussions. We want to always reevaluate the role, like what are the benefits and risks of the nutrition support moving forward. But it might be appropriate to continue to provide the nutrition support if there's improvements in quality or quantity of life, if the benefits continue to outweigh the risks, and if it continues to be aligned with the patient's wishes or their personal goals. But we need to realize that AA and H during the terminal state of cancer can look different. On this slide, we're going to focus on the 3 studies that I cited below and look at the results. So the first one is Ragemaker et al., which was a systematic review that they did in 2011. They included 5 studies that looked at the effects of just artificially administered hydration, so IV fluids with terminal cancer during the last week of life. 2 of those 5 studies noted that the people had less chronic nausea, they had less physical signs of dehydration, whereas 4 of the studies show no impact on delirium or fluid overload or thirst. Barrera in 2013 was a randomized controlled trial in which the top authors sought to determine the effect of, again, the IV fluids on symptoms associated with dehydration, quality of life, and survival in people with advanced cancer. So they randomly assigned 129 patients with cancer from 6 hospices to receive IV fluids of either 1 liter a day of normal saline or a placebo of 100 milliliters per day of normal saline. And this was delivered over 4 hours daily. Hydration at 1 liter a day, so more hydration, did not improve symptoms or quality of life or survival when compared to the placebo. And Wu did a study in 2021, what was an observational study, in which they looked at IV fluids, and they noted that they did not prolong survival, nor significantly improve dehydration symptoms of terminally ill cancer patients, but that they might enhance the quality of death. So there are some proposed positive effects of IV fluids at the end of life for cancer, including preventing delirium, opioid toxicity through increasing the renal perfusion of the opioids. But we also know that there's complications. We know with TPN that you had to get a central line. There's that increased risk for sepsis. As we discuss with the family approaching the end of life, the last weeks or months or so, the body starts shutting down, and this might make it difficult to process artificially administered nutrients, particularly fluids. So if they have enteral nutrition, it might cause diarrhea or abdominal pain. It might cause fluid overload for any sort of artificially administered nutrition and hydration. But communication with patients and their family on the effects of hydration might help them better prepare for the end-of-life experience. But however, we need to consider if appropriate hydration may meet the psychological needs of the patient and improve their quality of death, and taking each case individually. So here is our next case scenario. We're going to have a poll after this, so get ready. This is a 47-year-old with breast cancer with mets to the bone. She has been getting treatment, but unfortunately, her treatment response has been poor. She has been given weeks to live. She's had significant weight loss over the past 3 months due to nausea, vomiting, and she's gotten dehydrated to the point of being delirious and having hallucinations. The dilemma is that you discuss artificially administered nutrition and hydration along the way. The patient had always declined it, but now the patient's family are asking, would TPN have a role right now? So I'm asking you. Let me get that other poll forward. Launch the poll. Okay. How would you move forward? Would you pursue with TPN? The patient's malnourished. She's not able to keep PO. She's inquiring about it. Decline offering it. Remember, like, if you deem that the risk outweighs any sort of benefit, then you don't necessarily have to offer it legally. Or should we meet in the middle? So discussing maybe not TPN, but artificially administered hydration, so IV fluids as part of symptom management. Again, there's no right or wrong answers. Give you a couple more seconds to respond. Okay, so the majority of you, 69 or 70%, put that you'd meet in the middle. And that's really what I would do as well. I don't think full TPN would be appropriate in this case. However, let's go back to how artificially administered hydration may improve quality of death. We know IV fluids are common throughout cancer treatment. Therefore, patients and families may view IV fluids as benign. We know IV fluids may also allow the family and patient to feel like they're providing something. The patient's symptoms of delirium and hallucinations, let me close the poll, may improve with the IV fluids, but this always needs to be looked at in the big picture. So for example, if the patient's albumin level is very low, we know all those fluids may just third space and build up in her lungs, causing more harm than good. So I think it's always best to discuss the risks versus benefits of IV fluids with the interdisciplinary team first before offering it to the patient. Next up, we have our last population, the ones with the end-stage disease or terminal illness. So during end-stage disease or terminal illness, you often have decreased appetite and this inability to tolerate or enjoy food or fluids. Patients or surrogate decision makers may notice that their loved ones is having weight loss and they have this lack of intake, and therefore they inquire about ANH. Families, like we talked about, may express concern about their loved ones starving to death without nutrition, even though we know that studies say that individuals in the terminal phase of disease often deny sensations of hunger. Again, the decision to provide or forgo AANH can be laden with emotion for patients and families. So I really want to emphasize this is a hard decision. Nutrition is often symbolic. It's deemed integral to hope and survival, and the decision to forgo it can really be morally distressing. And then along with that, we have beliefs and attitudes about nutrition and hydration being rooted in religious beliefs or ethnicity or culture. But starting at the top with appetite. So decreased appetite and oral intake is part of the natural dying process. The body is now in this catabolic state, not an anabolic one. And when the glucose stores run out, the body begins metabolizing fatty acids and releasing ketones. And ketone production can lead to this feeling of euphoria. In addition, there's reduced gastric stimulation and hypothalamus function, which paired with the ketones leads to somnolence and satiety. Next, we have diminished thirst. Renal failure at end of life leads to uremia, which is this buildup of urea, which decreases thirst. And instead of providing fluids parenterally or enterally, I always suggest alleviation of thirst from less invasive measures. So good mouth care, mouth swabs, lip balm, ice chips for comfort. diminished pain. So protein breakdown produces dynorphin, which is this endogenous opioid that your body makes that helps with pain relief. In addition, hypernatremia causes decreased nociception, which is the body's ability to detect pain. Studies have showed that when you provide AANH in the last phase of life, it often blocks the body's natural mechanisms for pain relief, and in return, it causes them more pain. And then harm. There is harm with providing AANH at life. With kidney failure and, like we talked about, low albumin levels, there is the chance for fluid overload and third spacing. And so these fluids are going to the lungs. It might cause a person to have to be restrained. They might be pulling at the lines or tubes. For enteral nutrition, again, the GI tract is slowing down. So you might have more bloating or pain or vomiting or diarrhea. Your body's just not processing that nutrition. Parental nutrition, in addition to the fluid overload risk, obviously you have a central line, so there's always that risk of sepsis and fungemia. So moving on to our last case study. This was a person with ALS that I took care of. He's a 55-year-old male who's had ALS for 3 years. And ALS is often referred to as Lou Gehrig's disease. It is a terminal disease with no cure. The average lifespan of people with ALS is 2 to 5 years, and he's had it for 3 years. He has had severe dysphagia, so he did get it pegged 2 years prior, but he's been tolerating less and less tube feeds. We have switched from an intact protein formula to a peptide-based formula. We switched from bolus tube feed to gravity bags to pump-administered feeds. But unfortunately, he's admitted to the hospital for tube feeds coming out of his trach, and they diagnosed him with an ileus. The dilemma is that the patient knows he doesn't have much time left. He doesn't want to be in the hospital. He wants to get home as soon as possible. So they discharge him home on terrific feeds. And the wife, who is actually a dietitian, knows the importance of nutrition. And then she calls me to see how we can advance the tube feed to go at home. However, the patient states he's comfortable at this lower tube feed rate, and he's refusing to have the rate increased. So here is our last poll. I'm going to pull it up for you. Okay. So how would you move forward? Would you switch to an elemental tube feed via pump and advance as tolerated to goal? Would you start supplemental TPN for now and plan to wean the TPN once we get to goal tube feed? Or would you continue tube feed at a lower rate as tolerated and talk with the family about that tube feed intolerance is common at end of life? I'll give you about 5 or 10 more seconds to get your polls in. Okay, so the majority of you said continue tube feed at a low rate as tolerated. So 90+%. And honestly, that's what I went with. Though the wife was a dietitian, she didn't work with people with terminal diseases. However, she was receptive to what I had to say. And we talked about how her husband's body was shutting down and that pushing the enteral nutrition would likely cause him to be uncomfortable and possibly refluxing back into his trach again. I informed her to anticipate weight loss with the lower tube feed rate, and that the overall goal would be his comfort. If at any point he was hungry, we would obviously increase the tube feed rate. And she was amazing. She was so attentive. She routinely assessed his desire as to what he would want with a tube feed based on how he was feeling. And soon after, he went on hospice and he actually passed away a couple weeks later. I try to be careful about suggesting patients may be in their end phase without having a provider first prognosticate that. But I do think it is really important to prepare the family that there might be a time when their loved one no longer tolerates nutrition support and to not push it on them, as that might cause them more harm or distress. Here are some communication strategies to help guide conversations with patients and family in discussing artificially administered nutrition and hydration, especially in those more controversial scenarios. So first, recognize the sensitivity of the topic. There are lots of emotions and cultural and religious beliefs surrounding these devastating diagnoses and AANH. Always aim to avoid making the patient or family feel like they're not doing enough, that they're not feeding them enough, or they're not eating enough, that they're not trying hard enough. Patients and caregivers really need to hear that they've done an amazing job, but it's really just the nature of the disease or situation that's leading to their decline. Always communicate the same message as the interdisciplinary team. I cannot emphasize this enough. It's extremely confusing when the patient or family hears mixed messages from different team members. It can ruin trust. It can create conflict. It can diminish the credibility of the medical team. So meet as an interdisciplinary team first to all get on the same page before meeting with a patient or family. Next is be honest, transparent, and respectful. We have an ethical obligation to provide truthful information about AANH to patients or their surrogates. And the team really needs dietitians to help lead or at least be part of these discussions. Avoiding the topic of AANH may be perceived as you lacking knowledge or being deceptive and withholding knowledge. But remember, in many facilities that patients and families now have access to your notes. So you might as well address it because you're probably going to be addressing it in your notes and they're going to be reading it anyways. Avoid bias and judgment. So we all have our own beliefs, our own experiences. How we would handle a case may be different from how a surrogate decision maker is handling the case. But it's important to focus on the well-being of the patient and their personal goals. Avoid medical jargon. So no matter how educated someone is, medical terminology is really a language of its own. So don't just assume that a patient's spouse, though they might be the CEO of a really successful company, knows medical terminology. Because let's be real, a lot of people aren't going to ask you to repeat something more simply because they don't want to feel stupid. So go ahead and use simpler words, shorter phrases, more easily understandable information. Ask open-ended questions and give ample time for the patient and family to ask questions. The rule of thumb is if you are talking more than 50% of the time in these discussions, you're talking too much. Seek understanding if needed. For example, maybe the surrogate decision maker says the patient would have wanted AANH if they could maintain some quality of life. So seek understanding how the patient would have defined quality of life, as that really differs depending on the different people. My husband and I always joke about that. He says he would be completely fine if he was 100% dependent, yet sitting in front of a TV, eating ice cream at a nursing home. And if I ever had a major stroke, I wasn't able to complete my activities of daily living, I've told him I would not want that life. It would not be for me. So really define what quality of life is and seek understanding. And then lastly, give room to discuss feelings. I know this can be really awkward. Always have tissues on hand. Allow for silence while people process those emotions. Remember, this is somebody's daughter or son or spouse or parent. If appropriate, express sympathy by putting your hand on the shoulder or knee or even giving a hug. And whenever emotions or silence comes up, do not fill the room with more medical information. Just let it be. Silence and nonverbal empathy can be really therapeutic. Sometimes conflicts arise between the team and the patient or family, and this might happen when the patient declines a therapy that the team has deemed beneficial. For example, maybe they just got this new diagnosis of short gut, short bowel, and they're declining TPN. Or if the patient or family requests the clinician to act in a way that might bring harm, providing AANH in extremely what we call low yield cases. Or the patient's preferences might require an inappropriate use of resources. And this can be particularly difficult during times of shortages. For example, if the family is requesting TPN, the patient is not really going to benefit from it that much, and there's other people that could use those resources more so. So successfully negotiating these conflicting views requires considerations of the right of the patient, but also their limits to autonomy. So starting at the top of the slide, first, seek if there are misunderstandings or miscommunications. I will say these are often the primary causes of conflict. Secondly, again, know that clinicians are not ethically obligated to offer the AANH if in their clinical judgment, they think the burden or risk far outweighs the benefit. And know that, again, we had these limited time trials as an acceptable alternative when the benefits of the ANH or the prognosis at large are questionable, and when the trial nature of ANH is communicated and agreed upon by all parties. If you're still unable to resolve conflicts, consider getting an ethics consult and having the ethics committee weigh in on the case. And lastly, if disagreement about care between the patient family and the team continues, consultation with and transfer to another provider or institution should be considered if all are in agreement, because this can really help ensure the patient and family that they aren't being abandoned, that you still care for them, that you're trying to be respectful of their choices, but that you need to transfer them. So in summary, AANH is a life-sustaining therapy, but it might be harmful in certain scenarios. Discussions surrounding AANH can be emotionally charged, and it's important to communicate well with the interdisciplinary team and the patient or family. In other resources, you have evidence-based medicine, you have the team, you have time-limited trials, you have ethics committees. Also build your confidence. A lot of this is through just experience and asking to join these conversations and really just getting involved. But at the end of the day, these cases can be really tough on you as an individual, as you as a team. So make sure you do care for yourself and your team, talking about it, debriefing about it. If you do this day in and day out, it can be really exhausting. You might need therapy. So make sure that you take care of yourself as well. And we're going to move to Q&A, but I also have some references on the slide.
Great. Thank you so much, Stephanie. That was really, really great. I learned a lot myself personally, and I know it's a hard topic. It's certainly hard to do in practice. So I commend you for sharing your knowledge on this topic. We have several questions. So first, there have been several people that have actually asked Stephanie, how did you get into the specialty of ALS? Is there a story there, or do you want to tell a little bit about that?
I feel like it's just my calling to treat people with terminal illnesses. I'm so thankful for the people that are working with babies in the NICU. I just know nothing about babies, even though I have to. But it's just been really a calling. And I will say that going from critical care, I would attend these meetings and they're highly emotional charge. I was in neurocritical care, so it would be a traumatic accident, it would be a traumatic stroke, and you're working with families and patients, and you don't have a lot of time to have these discussions. And I felt like we didn't do the best job at having those discussions, both as dietitians, but as a team in general. So I really sought to get better at these discussions. So I went through my palliative care team. They involved me on their rounds, which was really cool and insightful. They taught me a lot of tips. And then a position for ALS opened up. And, unfortunately, it's a terminal disease. All my patients are going to pass away. And I just think it's a real true honor and joy to come alongside people in this phase of life and to take care of them. So it's an honor. I love it.
Really, that was really well said, and amazing. Okay, so the first question is thoughts on TPN at end of life without labs. This particular clinician works in pediatric oncology, and often this is something the team wants to provide, but they don't want to continue to draw labs.
So I think, that is, labs are hard with the home setting. I think you have the burden of going and getting labs. Some can have nurses come into the home. It can be painful unless they're drawing from the line. So there is that extra burden of actually getting the labs. But I do think labs can provide some insight. I think you can do, especially at the end of life, a lot of clinical assessment. So determining what their hydration needs might be by just looking at them, looking at their skin, looking at their oral cavity. But I think every case needs to be weighed out. But I think, what are you going to see from those labs? Are you going to see their kidneys failing? Well, you might be able to see that from them only urinating once or twice a day. Are you going to see that their sodium's up? Well, you might just see that from their oral cavity being completely sticky. So I don't know. I think it's safer to do it with labs, but I don't necessarily think it's the end all be all.
Yeah, tough question, really good question. Yeah, it's hard to have concrete answers to any of this, really. It's very it's a difficult topic, like I've said, and like you really emphasized today. Another oncology specific question, although I think it can overlap to your ALS clinic as well. When you're discussing TPN at end of life, insurance coverage. So specifically, if somebody has an intact GI tract and but they're getting TPN for other reasons, have you run into insurance coverage issues with this, or any tips you can provide there?
So I think Medicare, most of my patients have Medicare, have the strictest guidelines, but a lot of the other insurances go off the Medicare guidelines and really they're saying if the gut's not functioning, if you've tried an oral diet, they're vomiting. If they've tried oral nutrition, they're vomiting. Diarrhea, not absorbing a lick of any nutrient. If they had continued weight loss, so that their oral intake is not commensurate, is not able to support their weight or strength, then I think you could get insurance coverage. But I think, always thinking in the back of your mind, what if we don't get insurance company or coverage? Like, is that going to be a huge financial burden to the patient? What are we doing here? Is it even going to be beneficial? I think, cognitively, psychologically, for some people, it could be, and they're like, I'm willing to take on the risk of knowing that it might be harmful, but I'm willing to try it. But I think it comes down to documentation and making sure that you document well, and knowing that we're not trying to totally screw over the insurance companies, right? We're trying to work in the best interest of the patient. And if you truly believe that the patient could benefit from the nutrition support, then I think just document it that way and give your reasonings why.
Question on what are your thoughts on the use of appetite stimulants when intervention has been exhausted in this particular population?
I think it's worth a try. I think all medications typically have side effects, so you have to outweigh that. So if you have something like Megace, if they are bedbound, knowing that a big risk of Megace is DVTs. But I think we do try appetite stimulants. I think it helps, again, psychologically, those families and patients that aren't there yet, in bridging that until they get to the point of accepting that my body's shutting down and I'm not going to eat well. So I think appetite stimulants definitely do have their place. You just always have to outweigh the potential side effects as well. Do I find them helpful? I haven't really found them helpful, because I think the body is just shutting down. And you can't really trick that. But I think for the family or patient, they feel like they're doing everything that they can.
How do you handle a situation where the provider or other members of the IDT are not in agreement with the dietitian's assessment of risk benefit of AANH? Or maybe they don't feel like the RDE should be involved in the end of life discussion. So how do you kind of positively input yourself into those decision making?
Yeah, I think it's really interesting when it comes to the team. I really have high respect for my team. I think you should always be involved before you go in these discussions, not just going guns blazing, hi, I'm new to the team. I think you really need to build rapport and respect within the team first and come ready for rounds, ready to receive information, to give answers. So I think a lot of that has to do with building the team's trust and respect for you as the nutrition expert. But I think a lot of it has just come with having a humble attitude and me asking, you're not going to get, chances are you're not going to get invited to the table and have in part of these discussions. It's not that physicians are intentionally not inviting you a lot of times. It's just that they don't think about inviting you, that they have always been the one having these discussions. So I think inviting yourself and starting it with, hey, I'm interested in learning how you have these discussions. I have never been part of them. I won't make a peep during this conversation unless you lead the conversation for me to answer a question. But I'm just here to learn and see how you do things. And I think that's a good way to get your foot in the door. And then I think just talking about it as a team, and again, seeing that a lot of disagreements might come from misunderstanding. Like I might be like, what are we doing here? This is terminal cancer. And they'd be like, well, actually in the past 3 years, we've really had advances in medicine and it's not so terminal. And that's what, so I found myself a lot of times like, oh, I just didn't understand everything. So I think coming with humility in the team and in working all together for the best of the patient, but also really knowing and respecting your team members.
We have several more questions here. So to the audience, I know we won't be able to get to all of yours, but we'll try and get through a few more here. This next one, Stephanie, is in regards to when you have a time limited diagnosis. So somebody who's end of life and you have an estimate of till when they are going to pass. How do you determine whether you're going to go with an NG tube or a PEG placement? Like, how do you make those decisions when you do have a time limited scenario, but obviously a time limited scenario isn't perfect? So if you can give us your thoughts on that.
Yeah, that's really tough. I mean, I do recommend, for a lot of cases, if they're already in the hospital, to try it in G-tube just to make sure that they tolerate the tube feeds. And saying that, at the end of life, the reason why we wouldn't want to provide ANH is that it might cause more discomfort, it might cause more harm. So giving a trial period of that with a PEG tube, you're not gonna really do a trial period because the PEG is there, right? But you can always be like, hey, we're gonna look, they're going downhill. Let's try tube feeds for the next week or so. But if they are having all these symptoms, and agree upon that, communicate that with the family, have them weigh in on what they're looking for, then at any point we're gonna stop it before the end of the trial.
A few legal questions in terms of nutrition support here. The first one came in after we were talking about TPN without labs. Is there any, in general, if you have somebody getting TPN that isn't getting labs, or if you have maybe a patient that's getting G-tube feeds, but it's not meeting their estimated nutrition needs, is there any liability to the dietitian in those situations?
I think as long as you document. With the labs, I would say in particular, that's for the person that has had pretty stable labs. Like I would feel most comfortable with that. It's just like they've been on the TPN before. We're not just newly starting it and not getting labs. But then always document to cover your butt. And even though you think that you're connecting the dots between notes, you really just got to spell it out for the person that comes behind you, the lawyer or whoever who looks at your notes, and just document that you again have had these discussions with the family, the interdisciplinary team, that the tube feed is not going to meet their needs, that you have discussed this, that you told them that they should be anticipating weight loss, and that they verbalize understanding, that they know that this is what's going to happen and that they're agreeable to the plan. So document all of those conversations as much as you can.
Yeah, good advice, good advice. And for the record, Stephanie is not a lawyer. So for those of you asking some of those questions, please consult with your legal team at your hospital. That is strictly just Stephanie's opinion. It was an amazing opinion, but I do want to say that. Now, for physician orders of life-sustaining treatment, do those always have an expiration date, or are they in place until something overrides it? There's been a few questions about the POLSTs.
So I know the POLST form. So that's really common in New Jersey and has to be signed off by a physician. I live in PA, so we mostly have to go off the advanced directives. To my knowledge, they aren't time limiting, but don't quote me on that. I don't know if they're good for a year. I know that you can always override them, especially like your power of attorney. So really trust your power of attorney when you are picking that person, because there might be an option that they have to follow your wishes verbatim as stated in that document, or that they can make the judgment call to override that. So I'm really not sure if they do have a time limit. But I know advanced directives do not, which is part of the problem. It's just like, you filled this out 40 years ago when you were healthy individual, and now you're not, and your decisions have changed on it.
I'm over here now thinking, which child should be my power of attorney? It will probably change for many years to come, which one I choose, and which one likes me the best. So
That's
that
right.
is,
I know.
so that is, we are at 1 o'clock, Stephanie. I'm sorry if we didn't get to your question. I just want to be cognizant of obviously Stephanie's time and everybody's time on. Thank you guys so much for joining us for this hour. I know I learned a lot. Stephanie, thank you for sharing. Again, this was approved for 1 continuing professional education credit by CDR. It does count as an ethics credit as well. If you were not able to get the certificate from the handout section, you will get an email that has a certificate as well. We please ask that you fill out that survey when you get the email so that we can continue to improve our webinar options here at Functional Formularies. So Stephanie, always a pleasure. Thank you, thank you. And to everybody out there, have a great rest of your day.
Thank you all for joining.
Bye, everybody.